Dr. Jayant, Dr. Ashwin, I can see both of them, Dr. Samir, Dr. Murtaza, and Dr. Tushar. Tushar, I'm not able to see. Tushar is there?
Oh, sorry, it's not.
Okay, fine. So I think Jayant is there, Ashwin is there, Samir, and Murtaza is there. So this is a case-based scenario, decision-making things. This is a not like my patient. This is a theoretical case of a 50-year-old Indian woman, no history of smoking, severe left back pain, breathlessness and cough for last 3 months. And the CT scan shows a solitary tumor in the left lower lobe with moderate ipsilateral plurification. Turned out to be adenocarcinoma, moderately differentiated, EGFR wild, ALK positive by ISC, and PET scan was done, which showed lung carcinoma with pleural effusion. In the PET only, there was a CNS disease which was seen apart from the spinal mets. So this is a case of lung cancer stage 4 ALK rearranged. So my question to Dr. Ashwin is regarding the CNS, talking about the brain MRI. Do you do the brain MRI before starting ALK therapy or not?
Sir, am I audible?
Yeah.
So routinely I don't do it. Only if patient is symptomatic or if I get any evidence on PET CT, then only I advise, or else no.
So your question is basically no, right? Dr. Murtaza, yes, you are doing for every patient or only symptomatic patients?
No, sir. I routinely advise MRI brain to all my stage 4 or advanced patient. Because sometimes we know sometimes some asymptomatic brain mets are also there. Then we have to choose before choosing our ALK inhibitor or EGFR TKI. We have to know what the brain status. So I routinely advise. Sometimes because of financial situation don't do MRI, but I advise and I want preferably patient undergo MRI brain.
Yeah, because if you see the first line drugs which have got approval preferred, basically even though they have CNS penetration, that most of them they don't require an MRI over there. Anyway, it's a very good thing you said. Dr. Jayant, do you do the MRI or no?
Yeah. So what we do at our setting is we do a dedicated brain imaging when we do the PET CT scan. And what we have found that we most of the times pick up asymptomatic mets in the PET scan itself. So we are not doing brain MRI as a separate thing for CA lung patients.
Okay, fine. Samir, what is, you do the same thing or you go ahead with MRI or no?
Yes, sir. I also prefer MRI doing routinely if patient is affording.
Okay, so you put the affordability over there. Otherwise, naturally, everything becomes a different story.
Right.
If the affordability is not there, then you have only one drug which you can think about giving.
Yes, that then doesn't make any difference in my treatment.
Right. I think it's very important thing to understand that, so one way or the other, I think most of us do think the presence of CNS metastasis, it impacts the decision in our cases or not. Samir, if the CNS mets is there, your thinking changes or you go with the same goal?
Basically, sir,
doing the MRI, since you're doing MRI, naturally, it will change, right?
Yeah. So basically, sir, for me now the crizotinib is now out first line. So for me, it's always second generation versus lorlatinib. So I think means even if the brain mets is present, so alectinib is also a fair choice. Okay, but maybe we have to think and give the option of lorlatinib also. But otherwise, if the CNS meds is not there, definitely the first choice is alectinib for me. So I think it helps in making decisions slightly and counseling also.
So if you are looking at the cheapest option, which one you will go?
Cheapest, then serotonin.
Fine. I think very practical thing what you are talking about. That's Jayant, any different thoughts or the same thing? Dr. Jayant, same thing.
Yeah, same thing, sir. If there are CNS mets, then second or the third generation would avoid the first generation.
So how much percentage you tend to see asymptomatic mets in your ALK positive patients in your practice?
Maybe around 30%.
Right. I think it's quite good. Samir, same thing or you feel it's more?
What, sir?
The CNS asymptomatic metastasis, ALK positive patients.
Yes, around same 20, 30% around.
Yeah. I think we are seeing in the same tune of around 30%. But most of the brain mets are asymptomatic. They don't get picked up even with the PET scan. This patient had a scan based on the PET scan, the lesions got picked up. But tendency to have a asymptomatic is very high with ALK, similar like EGFR. But the trend is changing now. Everyone is doing the MRI. That should become a part and parcel of most of the things, because we are deciding the therapy based on that, the CNS metastasis also. So it does impact our treatment decision. Small point to give you an answer about the baseline, the importance of baseline brain scan. You can see the ALEX, ALTA, and CROWN study, and where the PFS also basically in those patients where there was no brain mets, and those patients who had brain mets, there was a difference in the PFS. And so if you see all these trials from the alectinib to briga to lorlatinib, patients who had brain metastasis, they have underperformed in many trials. Any comments on it, Ashwin?
Yes, sir. As compared to crizotinib, I think second generation and third generation.
Basically, now crizotinib is becoming like a poor arm for everyone.
Yes,
everyone has done a trial comparing with crizotinib. So, and somewhere a reason could be the penetrance of the brain mets is not there in crizotinib. So the important thing is when we talk about the CNS as a site of metastasis, it's a most common site of progression when you are talking about patients treated with the crizotinib and ceritinib. The first site of progression on a crizotinib, the percentage is nearly 50% of negative cases. Similar with ceritinib also, it's in the tune of around 40 to 45%. And we know the reason why it occurs and the mechanism of resistance. Alternatively, this CNS progression may be due to insufficient penetration of this ALK inhibitors into the CNS, which enables the CNS as a century site. So, Dr. Samir, at the time of progression, you are doing again a molecular analysis or no? Looking for the resistant mechanism?
Yeah, sir, we should do it.
Okay. You do routinely or no?
NGS. Routinely, patients affording again.
Yeah, I think we are here only for looking at the affording patient first.
Yes,
we know from the first line, from what to do. Then now the whole things have changed.
Right, sir. We should do it.
So, So, Dr. Jayant, I think, can you elaborate the key factors when you are deciding on selecting the first line treatment? Looking at it now, you have so many options. We are now in the same way like EGFR, like the previous talk of Dr. Kumar. So Dr. Mehboob Basade and Dr. Kumar was telling. So we have so much of choices now. So how do you decide in your practice?
So basically, it is for us. It is second versus third generation.
Right.
There is no data head to head between them, so we have to fall back on cross trial comparisons for the two. Now, when you look at a cross trial comparison, again, if there was an overall survival data for the two, that would be the best thing to compare. You don't have an overall survival comparison even in the cross trial setting. Then we come to the response rates, overall response rates, the CNS response rates, the rates of CRs, and then the toxicity. These are the factors which help us to decide which drug you are going to choose. I think looking at the cross-trial comparison, lorlatinib seems to be better than alectinib as far as the cross-trial is concerned. Even if you look at the toxicity profile, you look at the discontinuation rate, they are almost numerically, they are almost the same, but numerically alectinib had a higher discontinuation rate as compared to lorlatinib, even though lorlatinib has more grade 3-4 adverse events as compared to alectinib. Then the next thing would be, how are you going to sequence your treatment after second and third generation? That would be again a factor while you decide what treatment you're going to choose first line. And
so
finally,
I think the whole thing basically is going the same way like the EGFR, where there's a lot of talk about the sequencing and the best drug to use it in the first line. So Dr. Murtaza, anything you feel is different? CNS is a criteria now. CNS has become a very important criteria. Even in the EGFR, but in the ALK also the CNS has become a criteria. Anything else you feel is a criteria when you're talking about looking at the consideration for the first line? Leave the cost factor.
Okay. No, sir. I basically see for the brain disease as well as the sequencing pattern. So I'm totally agree with Dr. Jain. If we want to sequence, then we should like think alectinib followed by lorlatinib or upfront lorlatinib followed by what mutations we got in NGS. So if we have some other options for uncommon mutations, then these are sequencing and brain mets will be my key factor for deciding upfront therapy.
Yeah, I think the only thing which is going to give us a good answer about is, you know, apart from the looking at the clinical evidence, you know, you will never get a trial to directly do a head-to-head comparison. This will never happen. The efficacy in the first line and is going to be a big factor. CNS, luckily, we know that the first line, the good second generation, and Lorna has got a very good CNS penetrance. I think this is something we know. Long-term safety, resistant pattern, you know, we have been struggling with drugs like, you know, the crizotinib and alectinib. Our basically experience is not so great right now with the lorlatinib because it has just come in the picture. I think second thing is that alectinib, all of us have used it for a good amount of time. And resistant pattern, we do talk, but you know, the previous discussion which was going on was which is the best drug to use at the first time. You cannot keep it for the second time because the survival happens based on that. Yes, you know, this talk about sequencing and using the first line will always be there. But yes, I think the problem which happens is a progression. When it progresses, the resistant pattern makes you go back to only one thing, that is immunotherapy or chemotherapy. Most of the, if you see the lorlatinib and other things, the problem with the lorlatinib is only that when they do have a resistance, most of this resistant mutation, they do not respond to any ALK inhibitor. So you have to go back to the chemotherapy. So
Sir,
this sequencing,
regarding toxicity, definitely lorlatinib is much more toxic than alectinib. So I don't know much.
It's not so easy drug. The
So
hypercholesteremia, I had two patients of mine, you know, both I had to stop it only because of many reasons related to the lipid profile issues. Nothing.
even CNS toxicities are seen with lorlatinib. Even neuropathy is quite common. Edema is quite common. So as such, lorlatinib is definitely looks toxic, more toxic than alectinib. Alectinib is much easier to give.
Yeah. So alectinib, I think one more thing is, Samir, maybe I think we are more happy with alectinib because all of us have done we have a good experience about using alectinib. So we have been using alectinib and the side effect profile is almost similar like crizo only, except for the, you know, all this pedal edema and other things is the only toxicity. And ALK, you remember, they are much better than the EGFR. The life survival is much better with the ALK patient as compared to.
Actually, sir,
Samir is a co-PI of lorlatinib trial. So he has a more, I think, more experience with the lorlatinib toxicity and the management. So he can guide us better about how he managed in all this his trial patient.
I've seen almost all the patient had some toxicity. Almost hypertriglyceridemia, hypercholesteremia, almost seen in all patients. Neuropathy in almost more than 50% of the patient. CNS toxicity was seen in one patient. And peripheral edema almost more than 50% of the patients. So I've seen much significant toxicities for lorlatinib.
So this hypercholesteremia occurred very early or a little bit later?
Immediately, sir. After 2-3 months, it start developing.
That's I think the first 3
almost all patients required atorvastatin, statins. Almost all patients. Even triglyceride significantly increases. So
no, I feel that lorla is a very different. It's not so easy drug to use it. Right. I had 2 patients experience. But both these patients, basically, I had used it after the alectinib failure, to be very honest. I had now used it in the first line. And both these patients had a lot of issues, especially in the first 3-4 months, you know, with the managing the lipid profile. Nothing. So Dr. Jain, somewhere I feel lorla is more difficult with whatever experience I have. Just like that.
Sure, sir. I have no experience. But on paper, yes, it looks more toxic.
Ashwin, you had any experience with lorlatinib? Most of us, except if you have been in a trial, then only like Samir, you must have seen in the first line, but most of us have used it in the second line only.
Yes. Sir, but looking at the side effect profile means for a non-metastatic non-metastatic setting, I think better would be to go ahead with sequencing of alectinib followed by lorlatinib.
So that is why, you know, this discussion about sequencing and all those things will be there continuing for the next 2-3 years. Don't worry about it. So I think Samir, what is your first choice? You know, you are more preferring the sequence or first line the best? Lola, the data is coming very strong. Huh?
Yeah, right, sir. So for me, right now, if the brain metastasis is present, the option of lorlatinib may be discussed and explained about that, everything about toxicity and everything. And again, after lorlatinib, we don't have any data other than chemotherapy what can be given. Alectinib, definitely the brain mets are not there. I will prefer alectinib followed by lorlatinib here.
So you prefer in sequencing?
Sequencing in brain mets also. See, alectinib also is good for CNS.
No, you have to go with one choice. Yeah, there is something
sequencing. Sequencing.
It's something you can't discuss. Dr. Jain, what will be your thing? Sequencing, or you will go with the first drug?
I would go with the third line, third generation first.
Third generation. Good. Ashwin?
Sir, sequencing. Alectinib followed by
sequencing.
lorlatinib. Yes.
So I think Murtaza will follow Samir.
Once we are failed with alectinib, I think Roche does provide NGS support also. So I would go with sequencing.
वो बहुत कम पैसे का इतना ज़्यादा महंगा नहीं. So anyway, Murtaza, what will be you will prefer the best drug in the first, or you will go for the sequencing?
No, sir, I will definitely go with the sequencing, as I have seen some toxicity with lorlatinib also with some Samir's patients. So I will prefer to go with the easy drug first, then we will see in subsequent setting lorlatinib.
Yeah, basically,
till date now it might be changed, the practice might be changed in the subsequent years, but till now I will prefer alectinib followed by lorlatinib.
So basically what I had been doing the last 6 to 8 months is the same thing. I had been giving an option, but I give the personal choice to them to go ahead with the alectinib first and then go ahead with the lorlatinib later on as a sequencing. But like what Murtaza said is very right. You know, our perception might change in the next few years. You know, when you talk about osimertinib and the afatinib, there the osimertinib is very less toxic. You see the toxicity profile of osimertinib is much less as compared to afatinib. Here the only problem which is going to be a thing is the cost, and second thing is the toxicity, which might make us think about something else. So these are the currently first line approved. We all know crizotinib is also part of the line. Ceritinib is the poor man's drug, still I say, because this is much cheaper among all, because the generic version is available. Alectinib is a drug which most of us have started using the first line in affording the population. Diga is the availability issue, and Lorla has come up in a big way now. It has got a first line approval in March 2021, and the EMA approval is still not part of the thing. Alectinib came around 5 years back, and like I said, you know, our experience with alectinib has been quite good. Remember one thing, when you see there's no cross trial comparison, you know. You try to go ahead with the cross-trial comparison and give an answer, but you know, you will never get a cross-trial comparison. Everything will be against as a crizotinib. Most of the thing ultimately will have to decide based on the either a new trial which looks at the sequencing, or based on the experience, or based on the side effect. So the median PFS you can see is approximately 3 years with the alectinib. Here, you know, it's showing a good, you know, we have to just wait. The data, I think, right now the data is looking very promising, but you know, the whole battle in the next few years will be whether you prefer the sequencing or whether you go ahead with the best drug in the first line. So these are the way we look at it. Just now we discussed, when you talk about there are trials where post alectinib, like Ashwin said, you know, Lorla has come up in the second line based on the NGS we do it. You can see the way the median PFS moves from 34 to extra 5.5 months approximately, going towards the 4 years. So brigatinib also is a good drug, but as compared to alectinib, slightly inferior, and its availability is an issue. So normally when you talk about the first line, the second line chances basically with the lorlatinib is little bit on the better side, because we know the resistant pattern, but the whole, you know, game line is changing. Talking about the ALK trial, PFS by baseline CNS metastasis status, you can see the difference. patients with or without CNS metastasis, the PFS was much better in the patients who do not had CNS metastasis as compared to crizotinib. And even patient with CNS metastasis, the PFS was, approximately 2 years. So it provides benefit, PFS benefit, irrespective of CNS metastasis at baseline. So that's a real question comes in that asymptomatic metastasis patient, whether really we need to do MRI, but most of us have started doing it as one of the part of the criteria over there. So CNS progression in patients with or without metastasis, alectinib, it protects against and treats the CNS metastasis, and it's significantly delayed the time of development of new CNS metastasis and the progression of existing CNS metastasis. So you can see a difference where the CNS progression gets delayed in those patients who do not have CNS metastasis at baseline. So this is a 5-year OS data after a duration of nearly 48 months for alectinib. The OS data remains immature. 37% of the events were recorded. You can see the difference also as our ratio 0.67. And these are the 5-year survival rate when you talk about alectinib versus crizotinib. You can see even for crizotinib, this 5-year survival rate was quite good, 45.5. And for alectinib, it was nearly 62.5. Like I always said, ALK disease, as I feel always they do well better than the EGFR patients. So there's when you talk about alectinib, it shows a clinically meaningful improvement, 62 versus 45.5% with the crizotinib. So this is the safety. Looking at the safety profile, I think the important thing to remember is alectinib is, all of us have gone through it. The serious adverse events were seen in some percent of patients, but the fatal adverse events were very less. The AIs leading to treatment discontinuation was around in the tune of around 14.5%. So, but with a 3 times longer treatment duration for alectinib, the rates of reduction, interruption, discontinuation were similar with alectinib and crizotinib. So it's a quite well-tolerated drug over a long-term use. So, Samir, what has been your experience with alectinib?
Sir, I've used in 2 patients, and I think both of them tolerated well. There were no toxicities, significant toxicities.
Okay, so main toxicity which you found was more related with the edema or something else?
Actually, sir, both of the patients had no toxicities. They have tolerated extremely well. There were no issues.
Okay, Dr. Jayant, what has been your experience?
So I have one patient with alectinib. He had presented with CNS metastasis. So he received radiation, and then he's on alectinib since last 3 years, and absolutely no toxicity.
Yeah. Ashwin?
So 2 patients I had seen. One patient is in CR, 3 years with no toxicities. Another patient was there a bit of, apart from anemia, but it is no manageable toxicities, no serious toxicities.
Right. So, Dr. Murtaza, anything looking at the safety, tolerability, I think you feel it is much safer and easy drug to handle?
Yes, sir, definitely. If we compare all other third generation like lorlatinib, and if we compare alectinib, much more safer compared to lorlatinib. Like only some in one patient in my residency days, I have seen the LFT derangement. I have seen. Otherwise, in my practice, 2 patients I use in 2 patients. Both are doing well. No any this LFT toxicity or other toxicity mentioned in the literature. So they are tolerating well.
So I think it's basically our experience which will help us going ahead with the alectinib. That's one of the reasons why we are more comfortable.
Sir, basically means, as you said, like EGFR, here the story is same. But if you see comparison to EGFR TKIS, here the difference is that here second generation ALK inhibitor are much more better.
Yeah.
In terms of efficacy, they are better. Toxicity, they are better. In EGFR, what is happening? The efficacy is much less and toxicity is much higher. So that's why here the picture is slightly different. Here it may be difficult for third generation to come in first line, maybe, but we never know. We have to wait for 2-3 years, and then we have a PFS and OS mature data. Then we'll have a better answer. But right now, I think second generation, they are definitely much more efficacious and much less toxic.
So I think the whole story will look into the toxicity and the thing, nothing else, you know.
Right.
What has, you have any vision issues with the crizotinib? You have seen any vision issues?
Sir, one patient in TMH, sir, he had one issue. I remember it was 4 or 5 years
Yeah.
back.
So,
Otherwise, not significantly, means I'm not seen much.
Yeah, if you-
Dr. Tajinder sir to conclude the panel
Okay,
discussion
fine,
as
fine,
5 minutes are left, sir. Thank you.
Yeah. So I think this is the looking at the toxicity of crizotinib, you know, the safety data, and the serotinib. When you talk about the serotinib, the main issues which I had seen is the GI adverse events as compared to anything. Serotinib is not so easy drug, but GI disturbance are very big problem. And this is a trial, I think someone had presented it also, the Crown study, phase 3 Crown study, and the you talk about the grade 3, grade 4 adverse events quite high, adverse event leading to permanent discontinuation, even though here it looks 7, but the grade 3, grade 4 side effects were more around 72%. And this is what I think Samir had been going on telling about the first two, one hypercholesteremia, hypertriglyceridemia. Initial days it becomes like a big issue, you know, they come with peripheral neuropathy, they have this increased triglyceride, hypercholesteremia, and cognitive effects. Cognitive effects are quite prominent, which I had seen in my practice as peripheral neuropathy. So this is basically, like I said, cross trial comparison, looking at the overall response rate. The lorlatinib, it was around 58% as compared to 75% with the crizotinib. CNS also both did very well, and the main thing which is going to be the thing is toxicity, the grade 3 side effects leading on to discontinuation. The discontinuation adverse event dose interruption was in the tune of 47%. And even though here it talks about discontinuation basically around 15% as compared to 9%, but the dose interruption which we commonly see with lorlatinib is very common. So I think this is a question which I asked. Most of us are looking at sequencing. We might go ahead with the other way out, but right now our preference is more into sequencing, because it's a drug where we talk about the preventive approach. We have one more second line drug which is available, and it will help us in countering that thing also. So I think I'll just summarize these are the guidelines from the NCCN for the second line. Lorla is always there. So this is what I was telling about the treatment sequencing. I think it's something which is, we are going to look at this 40.3 months these drugs, they progress basically. I think the only option is going ahead with the atezolizumab, bevacizumab combination, or going ahead with only chemotherapy. This, I think the IM Power 150 was the only trial which had looked into that particular group of patients. So of the 5 approved first line treatment option, alectinib is still the preferred first line and standard of care because it has demonstrated the longest PFS. It effectively protects against and treats the CNS metastasis. It's the only ALK TKI to have demonstrated a clinical meaningful benefit in OS versus crizotinib, and it's a well tolerated. We know about it, its safety profile when we are giving it for a long term. We have patients who have been taking it for the last 3 to 4 years also. So a wealth of evidence for alectinib in the first and for the support is used in the with the consistent results in the phase 3 trials also. So upon disease progression, we have second line drug also. Thank you everyone for a very nice discussion.
Thank you, sir.
Oh.
I think Nikhil Kumar sir is there. We can ask this question to him. What is his preference right now?
So I think sir must have been answering these questions like, after the Lorla has come over there. Sir has got a very rich experience in the first line because of the trial things also.
I also think it also depends on which side are we speaking on. Is it a raw sponsored session or is it?
Yeah, I think that, but somewhere down the line, the only thing which is going to make us decide is the toxicity. OC somewhere came in the first line because of his, hardly any toxicities.
Yes, sir.
But still, the time will tell us much more. Once our experience becomes better, I think we'll be able to answer it.
Sir, I agree with you. And I think Norla at 100 mg is quite toxic. And I agree to that. Probably it will go somewhere down the line, Dacomethane kind of picture when, we step down one dose and...
Yes, and try to get the same result. Right?
Yes. Yes, sir.
So Lola, the main issue is that the dose, I think once they bring it down, I think we might see, but it has to work in the same efficacy way also.
Thank you, sir.
Yeah.
Thank you, everyone. And